today's speakers. I am very excited to be joined by Deanne Kassim, from the Executive Director of Health Policy from Change Healthcare, and Dr. Stephen Waldron, the VP and Chief Medical Informatics Officer for the American Academy of Family Physicians. Of course, I am Catherine Pugh, and I'm the Assistant VP of Policy here at the eHealth Initiative. So for today, I am going to be going through the overview of our recommendations that we've laid out in the report, and then I'm going to ask Deanne and Dr. Waldron to go into some more details on their organization's policy priorities around COVID-19. Okay, some details on EHI's COVID-19 Federal Policy Work Group. We brought together the work group in April of 2020, and we met over the course of 4 months, and our goal going into this was to create a report with a set of policy recommendations to fully leverage health IT and digital health to fight COVID-19 and future public health challenges. And we had 5 meetings, 1 on each topic, and a presenter on each meeting. And we covered telehealth and remote patient monitoring, artificial intelligence and machine learning, broadband, health information exchange, and public health surveillance. By no means is this an exhaustive list of all health IT or digital health use cases in combating COVID-19, but we did focus on areas that we felt were primed for policymakers to take action to change the current status quo to create a more modern healthcare system. In some areas, which we'll go through, there were temporary changes put in place that make sense to be made permanent after the public health emergency ends. Before we get into the overview of the recommendations, I did want to acknowledge our work group members. Our work group members here are listed here, and as you can see, we had a wide variety of stakeholders that contributed to the report. We're very thankful for their time and effort. I'd also like to highlight the organizations who endorsed the recommendations in the report and the work of the work group, who are listed here, and they are listed at the end of the report as well if you want to take a look at that later. I'm going to launch into the overview of the recommendations now, but I wanted to highlight a quote here, which I thought from the report, which I thought was very good quote. And it really highlights the fact that a lot of us and many of you on the line have been working in digital health for a long time, and we've known that there changes needed to be made. And this was a mission for us and has been a mission for EHI and all of your organizations for a long time. EHI has been around for 20 years, and we've been pushing this, but we recognize that the COVID-19 pandemic has certainly changed the dynamics. And we want to, in the last sentence, it says, prior to COVID-19, most incentives, regulations, and laws revolved around in-person care, siloed public health data, and in some cases, legacy technology. And we want to change that moving forward, and that's really what our work group and our goal here is at EHI. So our first area that we explored is probably the area of digital health and health IT that's had the most attention over the COVID-19 public health emergency period. As you all probably know, prior to COVID-19, especially with regards to reimbursement, there were statutes, laws in place that restricted where patients have to be, Medicare beneficiaries have to be in order for Medicare to reimburse for telehealth services. With the seeming stroke of a pen, those restrictions fell away overnight, and we now, across the country, Medicare is reimbursing for a large amount of telehealth services, and many payers and state Medicaid programs have followed Medicare's lead. And the unfortunate aspect of that is that those are temporary waivers, and when the COVID-19 public health emergency period ends, the statute goes back into place. So that brings us to our recommendations that are included in the report. We have recommended permanently removing Medicare telehealth reimbursement restrictions, including restrictions at the location of the patient, allowing for reimbursement in urban areas as well as when patients are located in their homes instead of just medical facilities. We want to enhance the authority of HHS to determine telehealth eligible providers. We want to ensure that federally qualified health centers and rural health clinics can continue to furnish telehealth services. And we want to make the temporary waiver, which is specific to this COVID-19 public health emergency, give that waiver authority to the Secretary for all public health emergency periods. We also explored other non-reimbursement areas, specifically licensure portability for providers. We recommend that policymakers incentivize interstate provider licensure compacts that include mutual recognition and ensure that federal grants that are currently ongoing toward licensure portability only support mutual recognition interstate licensure compacts. And then on remote patient monitoring, which fortunately is not as restricted under current law in terms of reimbursement, we do call out a few areas of reimbursement that we want CMS to make permanent. And those include allowing RPM devices to be furnished to both new and existing patients and patients with both chronic and acute conditions. And then we also call for the establishment of a permanent Stark and anti-kickback statute safe harbor that would allow providers to waive cost sharing. Of course, we would be remiss to not mention that telehealth and remote patient monitoring tools are only as good as the network that supports them. And we then focus on broadband. And we heard a lot during the public health emergency period that rural areas were especially hard to access high-speed broadband services. And we call out the COVID-19 telehealth program that was funded through the CARES Act, through the Federal Communications Commission. We call for additional funding and to remove barriers to that program and focus the funding through that program. And then we also call for sustained and expanded federal government investment in rural broadband development. Moving on to artificial intelligence and machine learning, we have a couple of very interesting case studies in the report. I encourage you to take a look at those, at how AI and machine learning have been used during the pandemic. There are many more, but the report's already 20 pages long, so we couldn't include everything. But we call for, in AI and machine learning, increased federal funding for research and testing for use of these tools in 3 areas: research, treatment, and public health. And then we also call on government agencies to collaborate with themselves and also with private sector partners to produce best practices and to adopt industry standards for that data quality and validation. This is something that we hear over and over again, that different organizations have different standards for validating data quality and integrity when they go into these AI and machine learning tools. And of course, the tools are only as good as the data that drives them. And this is something that we think is very important. And at EHI, we would be remiss to have a report that didn't acknowledge health information exchange and interoperability. And in the report, we call for establishing a permanent 100% Medicaid match rate for health information exchange activities. The current match rate is 90%. And expires this year, I believe, and Congress must reauthorize that. We also call for better aligning federal regulations related to health information exchange and lab reporting standards. And finally, public health surveillance. This was a very interesting topic for us. I know Deanne is going to talk about this and next in her presentation. But we have called for Congress to fund a study on the potential outcomes of moving from a vertical public health surveillance system, so a disease-specific or syndromic surveillance system, to an integrated public health surveillance system. And then we also, of course, call for restoring and protecting funding for the Federal Prevention and Public Health Fund that was established a number of years ago, but has been raided by Congress a number of times. And we think that that should be made permanent so that the public health infrastructure has a dedicated and reliable source of funding moving forward. So that is the overview of the recommendations in the report. I have included my email address. We're gonna address any questions at the end here for all three speakers. But if you have questions as you read the report later on, please feel free to reach out to me at any point. Great, Deanne, I'm gonna turn it over to you.
Great, thanks, Catherine. As Catherine alluded to, one of the areas that myself and my colleagues here at Change Healthcare have been taking a deeper dive on is how to really look at the existing information infrastructure that exists throughout the healthcare system and the data included in that infrastructure, and really use that to build up the public health infrastructure and data that is available for syndromic surveillance. And that would include such use cases as contact tracing, things of that nature. I think we can all agree that this pandemic has really laid bare all of the things that are not working within the regular healthcare system, including payers and providers, but especially on the public healthcare system. Next slide. So back early in the spring, the folks at Duke Margolis put together a well-known bipartisan group of researchers, just really smart people that have a lot of knowledge of public health infrastructure, what exists, what needs to exist, and just what is existing also in the regular healthcare system. And included in that, of course, would be health information exchanges, or HIEs. Actually, one of my colleagues, Erin Malik, who is a senior vice president in our research and development group and also sits on ONC's high-tech committee, joined in on this policy roadmap, which was released on May 1st. And this really laid out a roadmap and policy prescription, if you will, as to how to use existing data systems to improve the flow of critical information, and also use those existing health networks. So, you know, disclaimer, Change Healthcare is the service provider to Commonwealth, but with this paper, and I encourage those of you who want a deeper dive to look it up, it's available free on the internet. But how could we build off of using these large frameworks, and that includes Commonwealth, and through that care quality, to provide not only data standards, which we've invested so much, either with the current ONC and CMS interoperability and information blocking rules, or really just, you know, I could look back to meaningful use. We've invested a lot of time, effort, and money in getting to interoperable data standards. So the idea of using these large networks, the regional HIEs, and also eHealth Exchange, which of course is a trust framework that the federal providers such as VA and DoD use. So, you know, really this was something that put that policy in motion and asked the federal government to look at what it would take. We took this actually to legislatures as well, legislators, I should say, and say, you know, what is needed legislatively as well as regulatory policy to really start building on this roadmap. Next slide. So I recently stumbled across an interview that Ed Simcox, and for those of you who don't know Ed, he was the CTO of HHS, and then earlier this year left to go take a chief strategy officer position with LifeOmic. But I thought his interview, which he did earlier this month actually, you know, looking at the recently announced federal regs, including the information blocking rule, and really just doubling down on data standards and moving the needle on interoperability. And I think a lot of us do feel the same way Ed does in terms of wishing that we had these rules in place and that perhaps it would be further along our interoperability journey. But, you know, okay, we're not, here we are. But, you know, from a data perspective, this is, I think, an important start, as Ed pointed out in his interview. Next slide. So since we did the Duke-Margolis report came out in May, I looked at where's the government now? What is the CDC, what is ONC, what is HHS in general looking at doing, given everything that we have encountered with the pandemic since earlier this year to where we are now. So this summer, the CDC and ONC put together a report and accompanying executive summary looking at what is needed. And I took a lot of snippets from this report. If you're interested in doing a deeper dive, I cited the link so you could do so. But really one of the ideas is looking at data standards and health information exchanges, which is exactly what the Duke-Margolis and actually HITAC had discussed that earlier this year as well. But it comes down to all of those things that those of us who have really been living and breathing the CMS interoperability rule and the info blocking rule from ONC, looking at core data elements, standard APIs. How can we use that to get data out of these existing infrastructure frameworks and into the hands of public health? How can we really leverage everything we've already set up? How can we improve it, because not every HIE is as sophisticated as others? And how can we take that data and then get the states to where they need to be as well? We've definitely seen a lot of capabilities all over the place with states. And I think, as our report mentioned, Catherine, the fax machine is still in play in many state systems, unfortunately. Next slide. And so the report, does actually put forward this policy saying that HIEs are well positioned to assist state and local public health agencies. And actually that's something here that Change Healthcare has been working on with Commonwealth, to look at that use case and how we could leverage that data and through them care quality to add towards these public health data use cases, including social determinants of health, and really putting together that longitudinal data that is so needed to look not just at surveillance, but as we move forward, what are the health outcomes? We've heard about, just from COVID-19 alone, long haulers, these people that get it, they're sick, they're getting over maybe the worst part of it, but they still suffer symptoms and issues and health problems over the long term. How can we take data out of this infrastructure and look at all of the other factors that might be playing into this, and really answer some important questions? Why? How could we even take this and leverage it for clinical trials? So there's certainly a lot of use cases here, and I personally was very pleased to see that ONC and CDC started this conversation, and hopefully we'll start to continue this conversation. Included in that, though, and I think in our report we highlighted some of the asks, and the other one is funding. So how can we really maintain a sustainable source of not just federal funding to continue this effort, but also funding for the states? I think part of the reason we are in the state that we are in with public health data is we started to take this very seriously after the terrorist attacks of 2001, which then moved into anthrax. And then, like so many other things in government, other priorities take center stage or hit the center of the radar, and other things fall off. Next slide. So one of the things that we talked about, not only in the Duke-Margolis approach, but this is also something that is mentioned in the CDC report, is coalition of the willing. And I love that comment, even though it could kind of be a cliche here inside the Beltway. But the CDC report does really look at public-private partnerships, and this is really what it's going to take to get those data partnerships, get those infrastructure partnerships, but also how do we really upskill the current public health workforce? And I love that, because it's not just the technology, it's the people. And the idea of public-private partnerships can bring together such stakeholders as EHI, as HIMSS, as other organizations to really come together and say, what's the roadmap forward? What do we need to do in the private sector? What do you need to do on the public sector to move this forward? And they also talk here about a federated data exchange model, which is some of the things that we've been looking at, not only with Commonwealth, but with the existing resources that are out there. And of course, the importance of cloud-based technologies, getting data to be not only interoperable, but liquid. And back to, of course, our FHIR-based approaches, so evident, not only in the recent ONC and CMS rules, but that really is the standards that we need to use for the future. So let's get everybody using the same standard. Next slide. Thanks. I look forward to questions.
Great, thank you, Deanne. We're going to turn it over to Dr. Waldron now to talk about some of the priorities of the family physician. Dr. Waldron.
Thank you. Thanks, Dan. I think you did a great job talking about the challenges that we have ahead of us and the opportunities on the public health side. And definitely we're concerned about when the vaccine comes, managing that and making sure that we do that in a way that makes sense. And how do we make it easier for our docs and others to manage the case reporting that we've really struggled with during the pandemic moving forward. But I want to focus a little bit more on telehealth, because I think the iron is hot and there's a real opportunity for us in this space. Next slide, please. But first, when I think about kind of a modern healthcare system, I think about a system that enables smart health IT that's leveraging a lot of these new innovations such as cloud and voice and artificial intelligence, machine learning, and of course interoperability, which we've been working on for decades, to really empower the physician and the patient to achieve that quadruple aim. So I think the report did a great job of hitting a lot of these key parts of the AI piece, the interoperability piece, and what is the real goal that we're trying to accomplish. But again, I want to talk more about telehealth because I think there's a real opportunity there right now. So next slide. And when I talk about this, I try to think about it as kind of a jet doing this high G maneuver, right? So it's going along, it's cruising at a particular direction, and all of a sudden it makes this abrupt, complete change in direction. Applies a lot of force, not on the technology, but also on the individual piloting the system. And I think that's what's happened to medicine, and definitely happened to family medicine during the early part of the pandemic. We did a survey in May, and at that time, about 13% of our docs prior to COVID said they were doing some type of telehealth in their office. And by that time in early May, 94% of our docs were doing telehealth, and many of them were doing completely virtual telehealth. So they did maybe even a 7 or 8 G turn where they went strictly from in-person to strictly virtual in that period of time. And the next slide, I think the really good thing though, is you think about how that chaotic time that we had back in May and the challenges of doing that. And unfortunately, many of our docs were providing teleservices before the payers had made their changes to be able to reimburse. So some of our docs, about 40% during that May timeframe, weren't even getting paid to do this. You take all that together, and almost 3/4 of our docs said, you know what, we really like this virtual care. It's really working for us, and we think our patients love it. So the 86% on patients is kind of the physician attitude. So we didn't ask the actual patients, but so we think that's pretty accurate, but not 100% accurate in regards to what the percentage was. But seems like everybody is satisfied with it. And you compare that with the changes the payers have made and the 30+ bills that are in Congress around telehealth. We think that people think about telehealth and it's here to stay in some fashion, and we're not going to go back to the pre-COVID levels of telehealth. Next slide, please. And when we asked our docs, well, are you going to continue delivering on virtual visits moving forward? And almost 70% said they really want to do that and want to find a way to continue telehealth beyond the pandemic. But unfortunately, there's a lot of challenges and limitations to being able to do this. The payment models prior to COVID were very challenging to do that if you were part of a fee-for-service model. If you were in a value-based care arrangement, you had a lot more opportunities. Or if you were in a direct primary care model, you had really opportunities to provide telehealth in the pre-COVID environment. And we saw them rapidly adopt this technology and pivot, where our folks in the fee-for-service model struggled to kind of move that forward. And what we found too is that a lot of our docs, about 54%, said that they were using some type of consumer grade technology and we're not using kind of BAA covered HIPAA solutions. So as we think about transitioning after the pandemic, they're gonna have to figure out what they're gonna do with that technology and how they're gonna switch to some other type of technology. So when we think about a lot of those limitations and challenges, I think there's some opportunities on the policy side to be able to move us forward. Next slide, please. And as I look at those, and I realized that my subconsciousness thought there was a lot of policies here that we could do because I accidentally pluralized policies and strategies. So there probably are multiple policies for each strategy. So it's probably not inaccurate from an informatics standpoint, but from a grammar standpoint, sorry about that typo. But I think these are some of the big strategies. When I think about policy, we can get into the very specifics, and I think the report did a great job elucidating some of those specific policies that need to be considered. But some of the strategies I think that are really important is to make sure there's a clear statement of intent by payers relative to telehealth payment. So I mentioned the 54% that have consumer grade technology now in practice. They're trying to figure out, do I invest in a HIPAA compliant solution? Do I invest in process redesign in my office? Do I invest in people trying to figure out how they help me do this in a team-based approach to that? If I don't know that I'm going to get reimbursed and think that it's going to go back to that pre-COVID levels, people are hesitant. And we know that our practices are very financially fragile right now because of the decrease in revenues from the volume reduction they've seen with the pandemic. So I think as soon as and as quickly as payers can give an indication of what they're going to do relative to telehealth payment in the post-pandemic era, would be helpful to make sure that our docs are able to move forward. We're excited to see some of the intent from CMS in the current physician fee schedule that alludes to that expansion. We'd love to see the private sector be able to do that and continue to see CMS provide those clear directions moving forward. So even if we get those directions, the next piece is I think there needs to be consistency across payers and governing bodies. We have a lot of different rules and regs and payment models and payment schemes relative to telehealth, and all that inconsistency just adds to the administrative burden and waste in the system. So whenever possible, how can we make sure that these policies align across these different governing entities or payers, such that when practices and patients see this, they see a consistent model that they can pick up and use in a systematic way in their practice or in their life. The next is I think the policies need to recognize telehealth as a modality and not the separate new delivery model. Unfortunately, in healthcare, we already have too much fragmentation. And if we try to set these things up as completely thinking about them as completely separate new entities delivering care, we have a tendency to add more fragmentation to the marketplace. So I think we need to think about our policies and payment model and stuff like that. Think about telehealth as just another modality. So how could a regular practice that has inpatient and doing telehealth, how does that work together in a way that makes sense? Because we know that we need to have continuity, we need to have care coordination if we want to be able to see the quadruple aim and decrease costs and higher quality care. Not saying that there's not a significant and valuable role for standalone telehealth, but we need to think about those as two different types of operations. And lastly, as the report says too, we need to make sure that we acknowledge that there's a digital divide and that we need to continue to work to support the narrowing of that. So the broadband access stuff is really important now. When we've now expanded the originating site to be the patient's home, where before in telemedicine, it was really about medical facilities having broadband. We're now talking about individuals making sure they have enough broadband in their home so they can take advantage of these telehealth services from their home. And in addition to the broadband, there's still an opportunity too to make sure they can afford the devices. So if you're in a lower socioeconomic status, you may have access to broadband. You may be in an inner city that has 5G, but if you can't afford the plan and the tooling for that, you're still in the same boat as if you were in rural America. So I think these are some of the key strategies from our standpoint that we think are important. And again, I focused on telehealth because I think there's an inflection point that patients and providers are ready for this to be the new normal. And we need to make sure our policies are in place to make sure that we can grow that and sustain that over time. Thank you.
Sorry, I'm just pulling my slide back up here. Okay. Thank you both for those great presentations. I am going to, if you have a couple of questions coming in, so I'm going to pull these up. One question is specific to one of our recommendations, but I just want to broaden it a little bit. How do we ensure that all of the recommendations that we've put in the report for policymakers and all of the recommendations that you all have highlighted in your presentations, how do we ensure that those become final rule? How do we ensure that they be enacted into law or into policy? And of course, that comes down to advocacy, which EHI also leads. But how can organizations that are on the webinar that are interested in advancing these policies, how can they get involved and also support the recommendations?
Well, I can speak to that. Certainly EHI does advocacy. There's other groups out there such as HIMSS and many others that do advocacy. But I would also encourage folks on the call. A lot of these recommendations, not all, but a lot of them are in existence in bills right now in the House. So the HEROES Act, for instance, and now the skinny, watered down HEROES 2 Act, if you will, have a placeholder section for data surveillance, and would require ONC and CDC and HHS to work together to really study some of the recommendations that I just talked about that are in the report. And it's interesting because that language was started by Representative Lucy McBath, who has the CDC in her district. It's really bipartisan language, even though the HEROES Act is largely Democratic. There's also some bills out there in the House that talk about telehealth and how to really make some of those policy relaxations that CMS put in permanent. I know HR 7663 was one of the first bills out, and I think it was over 300 healthcare organizations signed on in support at last count. So I think a good way to start, since it is an election year, is find out who your House of Representatives elected official is and ask to talk to either their constituent office in your district or most likely the health policy person in their office, and really talk about what you want to see moving forward. There's a lot of things that may or may not happen between now and the election, and may or may not happen between now and the lame duck session, but there's a lot of good policies out there in some of the bills, and it's just a matter of, can we get them over the finish line?
Right, and I think if folks are interested in supporting telehealth in particular, Deanne mentioned HR 7663. We actually have an action alert on our website and our resource center where you can go and write your representative and ask them to co-sponsor that legislation. Okay, we have another question here. I think Dr. Waldron, this is a question for you. Are there recommendations going forward in the types of appointments that will be appropriate for telehealth? And would that help make the case to Congress to continue to reimburse for telehealth easier?
Yeah, that's a great question, because I think the way that we thought about telehealth and telemedicine, and we could talk for 20 minutes about the differences or not differences in those two terms. But, pre-COVID, it was really either kind of the consumer initiated, really a lot of acute care types of visits, or it was, a tertiary healthcare center delivering care to a local facility where the patient was at. The vast majority of care was delivered by that. There's definitely some exceptions with some of the behavioral health tools that are out there, but for the most part, that was a lot of the telehealth that was out there. Now with the pandemic, where we weren't allowed to provide in-person care as much because of the risk, we've identified there's a lot more capability for doing telehealth and doing additional services. So I think we're going to see a lot more medical services being delivered by telehealth, and there's a real need to understand the best practices for that. But I think there's some real opportunities to talk about that if it's being done as a chronic disease management type of activity, as an example, you have a less likelihood of having the problem where you have a telehealth visit by somebody that's not your physician, that doesn't know you, and then you are not satisfied and you go to the ER or you go to follow up. Because a lot of times in the past, telehealth was seen as a cost, not a cost saving, because they thought it would just increase utilization. I think there's a real opportunity to talk about how we're doing telehealth, and we'll be doing telehealth differently moving forward, and has a real opportunity to get care to patients faster, more comprehensive care, and therefore reduce the cost of total cost of care. So I think whenever we can provide those examples of where we've been able to provide that expanded service via telehealth, and it's related to higher quality and lower cost care, I think those type of examples are going to be needed for Congress to understand, and definitely the CBO to say, yep, this was going to save us money by doing this via telehealth.
And another related question, Dr. Waldron, can you talk a little bit about evaluation of telehealth as telehealth has increased over the public health emergency period? Is AAFP partnering, or do you know of other organizations that are partnering on evaluating not only what the data that you presented, which is satisfaction and utilization, but quality of care and basically what you mentioned, the data that we need to go to CBO and make the case?
Yeah, we have a policy center, the Robert Graham Center, and it is doing some of that type of research. And I would suspect there's many other organizations out there that are looking at this and trying to take this unfortunate opportunity that we have with the pandemic to better understand and study telehealth in a more comprehensive way than it's been done prior. So I'm sure there's multiple solutions, not solutions, but entities out there trying to do that. But we definitely are through our Robert Graham Center and doing that research.
And I know that there's also an effort, the person who asked the question mentioned NCQA. I know that they've partnered with the American Telemedicine Association and the Alliance for Connected Care on a similar effort as well. So if you folks want to take a look at that, I will direct you to their websites. Okay, another question just came into the chat box. There seems to be an opportunity for additional stimulus if there was a change in administration in January, especially if the Senate control changes. I guess this questioner is asking us all to be election prognosticators. It's tough. Is there potential that some of the technical recommendations made and highlighted today end up as part of the stimulus? And it could require a rapid turnaround from vendor stakeholders if these are enacted. Well, I'll field the first response to that. I think that is the goal of releasing this report now, is that we hope that at least some of these recommendations are included in the next CARES. Well, I don't even know what version of CARES we're on now, CARES V8 or something. But that's the hope with putting out this report today, that we can include some of these changes, of course. Anything to add? Others? Deanne, Dr. Waldron?
And you put yourself on mute instead of taking off.
Oh, Deanne, you're muted.
Sorry. I think we can certainly look for something to happen, maybe in terms of stimulus in the lame duck session, maybe not. Certainly, let's just play hypotheticals here. Let's say the Senate flips to Democrats and Vice President Biden becomes President Biden. Nothing in Washington really happens that quickly. Doesn't really matter who's in the White House or in the Senate or the House. But that said, typically the process for this would be that legislation is proposed, legislation is passed, and then in order to actually put guidelines around how details will be implemented, there is in the legislation saying the Secretary of HHS shall, or something that says the Secretary shall, and that goes out in a proposed rule, meaning the Secretary now has the authority to propose some sort of regulation, and they'll put a draft proposed rule out there for public comment before it becomes final rule. So there certainly is room for stakeholders to comment and make their concerns known with whatever a proposed rule ends up looking like.
Great. That's a great point, Deanne, in terms of the latter point of the question is rapid turnaround from the vendors and the regulatory process. Another question in the chat box, do you have examples of telehealth impact on vulnerable communities? And what does that look like in terms of adoption of telehealth? I can go ahead and say that from our perspective in the report, we do cite the utilization of telehealth in different communities that was released by CMS. Of course, that's just the Medicare beneficiary talking 65 and older and those who are disabled and on Social Security disability insurance and eligible for Medicare. But interestingly, utilization across different socioeconomic and race and ethnic breakdowns were pretty similar across the board. That's, of course, just Medicare population. I don't know, Dr. Waldron, Deanne, if you all have got other statistics in that area.
Yeah, I don't have statistics. I just have some anecdotes that I've heard from different members. We have one member in North Carolina that does a lot of substance abuse care, as well as his family medicine care. And he's been able to do a lot more doing the telehealth that way with some of the patients that just don't have the ability to actually get off work, travel, come to see him, come in the office, wait for the 45 minutes to be seen and get out. So he just saw a lot of no-show rate. So being able to do that, it's been helpful. And then I've heard a couple of anecdotes of people with physical disabilities that have it very difficult to be able to transport themselves. So being able to be seen multiple times when they would just kind of delay care because they didn't want to have to figure out how to get to the special van and just waste their entire half day just getting into there where they can actually be seen and have that conversation with the doc. So those are just two examples, but again, they're anecdotal. I don't have any statistical data that you mentioned.
That's a great point, Dr. Waldron. I think we've hearing a lot of those anecdotes over the course of the pandemic. Final question here, unless any others have any that they want to quickly throw into the Q&A box. To what degree were social determinants of health part of the EHI work group's recommendations, or was it out of scope? We certainly, in a lot of areas, touch on those issues under the buckets. And so in broadband, we talk about access to broadband for rural areas. And then we also mention those issues when it comes to bias in data for artificial intelligence and machine learning tools. And so we certainly have those issues mentioned throughout the issue areas in the report. And again, encourage you to read the report. But we also at EHI have a whole social determinants of health work group and data analytics work group. And as I mentioned earlier, we have on October 13th a webinar on the impact of COVID-19 in Native American communities. And we're going to be continuing those webinars on impacts in certain minority communities as we go throughout the year. And we have a report coming out on that issue as well. And so certainly have that issue top of mind and top of priority for EHI. And it's not called out as a specific issue area in this report, but it certainly is throughout the report, I would say. Okay, I lied. One last question. Someone got in before. The question is, any thoughts on documentation issues using telehealth? Has it improved or has it been difficult for physicians?
Yeah, that's a great question. Some of our, again, like I said, 54% were using something that was consumer grade. I don't know the exact percentage. I have to go back and look, but it was even higher than that we're not using an EHR's solution to deliver the telehealth. So they had two systems. They had a telehealth system and an EHR system. Most telehealth systems don't have as robust documentation capability as the EHRs have. And it may just be a text box. So they don't have the extra tools that they typically have in the EHR to be a little bit more efficient in delivering on that. So that's an issue. The other two is that you have now two tools going back and forth. So our docs all, and again, anecdotally talked about making sure they had two screens so they could have the EHR on one screen and the patient and the telehealth platform on the other screen. So it's definitely more of a challenge. There are some additional elements that you have to document, making sure that you verify that the patient is in a location that you have a license to practice in, and that you make sure that you've documented that you got consent for care, because for telehealth, you have to do that because there's a concern of fraud and abuse of people just calling up patients and having a conversation and then billing them for a telehealth visit when they didn't know that was the case. So those are some of the things that are out there. So I would say yes, but documentation is, this huge problem is too. So it's like putting another, gallon in a bathtub. Yeah, it makes a difference, but the bathtub was already pretty full with the burden already.
Deanne, as an EHR vendor, how are you working with your customers on that issue?
Well, we actually don't have EHRs here.
Oh, sorry, not EHR vendor. Sorry, I didn't mean vendor.
That's okay. I know there's a lot of things here, so it's easy to forget. Sometimes I forget everything we have here. But what we actually did is we took our API marketplace and started making a lot of those APIs on such as claim submission or eligibility checks available to telehealth vendors so that they could integrate it into the telehealth system and try to ease some of that paper burden or some of that electronic submittal burden. It's not necessarily a complete fix for all of the documentation that Dr. Waldron was talking about. I do think from things I've heard and people I've talked to, there are some ongoing communications and discussions and policy pondering, if you will, at CMS as to how can we make this more efficient going forward, but also not open up the door, as Dr. Waldron mentioned, to potential fraud, waste, or abuse. So I think we're right now in stage 1 of that. And as we move forward, there'll be additional technological advances with the vendors and different policy changes out of the federal government as well.
Yeah, and to the point in the report too about the need for more investment in AI kind of research, there is one tool that we've been working with that is a voice-enabled technology that has shown a significant reduction in documentation with our docs that have been using it in the pilots that we've been doing. They also had a telehealth solution there too. So we had a couple of our docs doing that. So I think there's some real opportunities in the long run using AI and machine learning to really decrease the documentation burden and really support practices and physicians and other clinicians to do that.
Yeah, agreed.
Good point. Well, thank you all for your participation today. And thank you to everyone who joined. I hope that you take a minute to read the report. Please follow up with us, with me, and anyone else at EHI. And we look forward to having you on our future programming.